Hello everyone, welcome to Patho Excellence. Today we are going to explore a classic and high-yield bone tumor under the microscope. Here in this high-power field, you can see numerous giant cells. In between there are some round cells and some stromal cells. So what is the diagnosis? Seeing these numerous giant cells with identical nuclei, think beyond just giant cells. This could be giant cell tumor of bone. It is also a benign but locally aggressive bone tumor, typically arising in the epiphysis of long bones in young adults. It is driven by neoplastic stromal cells and that recruit osteoclast-like giant cells via rank and rankel pathway leading to bone resorption and lytic lesions. The patients usually present with pain, swelling near a joint, most common around the knee, distal femur or proximal tibia, and may present with pathological fracture. Radiologically, X-ray shows an eccentric lytic epiphyseal lesion with classic soap bubble appearance and cortical thinning. Grossly, the tumor is soft, fleshy, red-brown with hemorrhage and sometimes shows cystic degeneration. So, let's see microscopically how you identify giant cell tumor of the bone. So, the tumor is composed of two main cell population, right? So, mononuclear stromal cells, which is neoplastic component, and osteoclast type multinucleated giant cells, which is reactive component. And when we see under the low power view, you can see tumor is in in the form of lobular architecture, and the areas of hemorrhage is seen here. And in between you can identify tumor cells as well as giant cell is distributed. So there you can identify in low power view easily. This is the darkly stained multinucleated giant cells, numerous in numbers, and this is the area of hemorrhage. Now in high power view you can see multinucleated giant cells and in between the giant cells the neoplastic component. These are the neoplastic cells located in between the giant cells. So, diagnostic backbone is mononuclear stromal cells. So, these are the cells which are mononuclear stromal cells, and this is a neoplastic component. So, these cells are oval to spindle shape, round to oval, and vesicular nuclei, small but indistinct nucleoli. So, cytoplasm moderate pale eosinophilic, and they are arranged in either diffuse sheets or in a short fascicle pattern, and mild atypia is visible. So, here you can see these are the mononuclear neoplastic cells, and mitosis sometimes present, and key point is these are the two neoplastic cells driving the lesion, not the giant cell. So now let's see about what actually the giant cells uh, arising from. So these are the osteoclast-like giant cells, numerous and uniformly distributed. They are multinucleated, having 20 to 50 nuclei per cells, and this is the hallmark feature. Nuclei resemble stromal cell nuclei, very important point for exam, and it is having cytoplasm, abundant and eosinophilic. So, diagnostic clue is nuclear similarity between stromal cells and giant cells. Now, giant cells are evenly dispersed throughout the tumor, not clustered around hemorrhage, and this is the differential point from another other lesions. So, what are the additional microscopic features we can identify in this GCT? Hemorrhage and hemosiderin. So, many areas of or frequent areas of hemorrhage and many hemosiderin-laden macrophages can be seen in this tumor. Necrosis usually absent, and if present, we have to think aggressive behavior or secondary changes. Here you can identify, see, this is the giant cell and these are the neoplastic stromal cells. Tumor may show bone destruction and sometimes reactive bone formation is minimally present. So now from this microscopy, what are the differential diagnosis? So differential diagnosis include, one is brown tumor, which is hyperparathyroidism origin. Here the key difference is uneven giant cells and clinically we have to see for hyperparathyroidism. Second is aneurysmal bone cyst. So here the distribution of giant cell is important. Here the blood filled spaces is there and septa is present and fewer uniform giant cells are present around this cystic wall. Now chondroblastoma, in which you can identify chicken wire calcification and chondroblast. Another differential diagnosis is non-ossifying fibroma, where you find storiform pattern of this fibroblast arrangement and fewer giant cells compared to this tumor. So basically giant cell tumor is two cell population tumor, uniform distribution of giant cell is present, nuclei of giant cell resemble stromal cells and no atypical mitosis despite mitotic activity. So this is giant cell tumor of the bone.